A 23-year-old man presents to the emergency department with a 6-hour history of palpitations. He has no past medical history. He denies chest pain, shortness of breath or loss of consciousness. He reports using ecstasy, MDMA, for the first time 2 days ago. On examination you note equal air entry with normal chest auscultation. You do not detect any murmur. His observations are recorded as heart rate, 170 beats minute. Respiratory rate, 20 breaths minute. Blood pressure, 143/95 mmHg. GCS, 15/15. An ECG is performed at triage which shows a regular, narrow complex tachycardia. What is the recommended dosing regime for adenosine in the treatment of a stable, regular, narrow complex tachycardia? Options are A. Adenosine 6 mg IV bolus, followed by a maximum of 2 further 6 mg boluses if no response. B. Adenosine 12 mg IV bolus, followed by 1 further 12 mg bolus if required. C. Adenosine 12 mg IV bolus followed by a maximum of 2 further 12 mg boluses if no response. D. Adenosine 6 mg IV bolus, followed by a 12 mg bolus and 1 further 18 mg bolus if required. E. Adenosine 12 mg IV bolus, followed by 6 mg bolus if no response. The answer is D. Adenosine 6 mg IV bolus, followed by a 12 mg bolus and 1 further 18 mg bolus if required. The first step in treatment of regular narrow complex tachycardias is to attempt vagal maneuvers, carotid sinus massage or Valsalva maneuver. If the tachyarrhythmia persists, adenosine 6 mg IV should be given as a rapid bolus using a large cannula and a large vein. If there is no response, i.e. no transient slowing or termination of the tachyarrhythmia, to adenosine 6 mg IV, a 12 mg IV bolus should be given, and if there is no response, 1 further 18 mg IV bolus given, max 36 mg. A 54-year-old man is brought to the emergency department complaining of central chest pain. He is overweight, BMI 33, and smokes 20 cigarettes a day. His ECG shows ST elevation in leads V5 to 6, 1 and AVL. You diagnose ST elevation myocardial infarction. Which coronary artery is most likely occlude? Options are A. Proximal left anterior descending. B. Distal left anterior descending. C. Left circumflex. D. Right coronary artery. E. Posterior descending artery. The answer is C. Left circumflex. Leads V5 to 6, 1 and AVL represent the lateral myocardium, supplied by the left circumflex artery. A 64-year-old woman presents to the emergency department complaining of 1 hour of central, crushing chest pain. What is the diagnosis? Options are A. Lateral STEMI, B. Anterior STEMI, C. Anterolateral STEMI, D. Posterior STEMI, E. Inferior STEMI. The answer is E. Inferior STEMI. ST elevation in leads 2, 3 and AVF, with reciprocal depression in lead 1 suggests an inferior MI. This is most commonly caused by right coronary artery occlusion. A 54-year-old man presents to the emergency department with a 3-hour history of palpitations. An ECG is performed at triage. What is the diagnosis? Options are A. Atrial fibrillation, B. Wolff-Parkinson-White syndrome, C. Atrial flutter, D. Multifocal atrial tachycardia, E. Torsades des points. The answer is C. Atrial flutter. Atrial flutter is a type of supraventricular tachycardia caused by a re-entry circuit within the right atrium. Atrial flutter is characterized by a sawtooth pattern of regular atrial activation at nearly 300 bpm on the ECG, best seen in leads 2, 3, AVF. Ventricular rate is determined by the AV conduction ratio, degree of AV block. For example, 2-1 block is equal to 150 bpm, 3-1 block is equal to 100 bpm. 4-1 block is equal to 75 bpm, as seen in ECG above. A 54-year-old woman is brought to the emergency department from the nearby psychiatric unit. She complained of palpitations and staff noted an abnormal ECG. Which of the following treatments is most appropriate for this patient? Options are A. Magnesium sulfate 2 grams IV, B. Amiodarone 300 mg IV, C. Metoprolol 5 mg IV, D. Adenosine 6 mg IV, E. Verapamil 5 mg IV. The answer is A. Magnesium sulfate 2 grams IV. The ECG shows Torsades des points. The treatment for Torsades des points is stop QT prolonging drugs, correct electrolyte abnormalities, give magnesium sulfate 2 grams IV over 10 minutes, obtain expert help, arrange immediate synchronized cardioversion if adverse features develop. A 40-year-old man presents with a 5-day history of a sharp, central chest pain. He describes the pain as worst on breathing in. He has no significant past medical history but has had a recent episode of sinusitis. What is the most likely diagnosis? Options are A. Community-acquired pneumonia, B. Acute pericarditis, C. Pleural effusion, D. Acute coronary syndrome, E. Pneumothorax. The answer is B. Acute pericarditis. The chest X-ray demonstrates marked enlargement of the cardiac outline. This is due to pericardial effusion and is a good example of the water bottle sign. This refers to the shape of the cardiac silhouette on erect frontal chest X-rays in patients who have a very large pericardial effusion. The fluid, often measuring a liter or more, causes the pericardium to sag, mimicking an old-fashioned water bottle sitting on a bench. Acute pericarditis is a clinical diagnosis. The diagnosis is confirmed in the presence of at least 2 of the 4 clinical criteria: typical chest pain, pericardial friction rub, widespread ST elevation, and pericardial effusion. A 54-year-old man presents to the emergency department after developing palpitations at work. On examination, his heart rate is 185 beats per minute, BP 123/54 and RR 18 breaths per minute. He reports no loss of consciousness, breathlessness or chest pain. He has no significant past medical history. Which of the following treatments is most appropriate for this patient? Options are A. Synchronized DC cardioversion, B. Amiodarone 300 mg IV, C. Metoprolol 5 mg IV, D. Adenosine 6 mg IV, E. Verapamil 5 mg IV. The answer is D. Adenosine 6 mg IV. The ECG and history are consistent with re-entry paroxysmal supraventricular tachycardia, SVT. There are no adverse features to indicate a synchronized DC cardioversion. If vagal maneuvers fail, adenosine 6 mg IV is indicated.